Hi everyone, welcome to Unit 7, Changes in Renal Function. In this unit, we'll focus on how the kidneys regulate fluid and electrolytes, what happens when kidney function declines, and how we assess and manage common renal conditions in clinical practice. We'll also explore dialysis care, urinary complications, and key safety considerations for nursing. Let's get started.
In this unit, we'll cover key topics related to kidney function and nursing care. We'll begin with CKD, dialysis, and potassium imbalances, then look at risk factors for kidney failure and how to care for a patient's dialysis access. We'll also review renal diagnostics, fluid and electrolyte issues, and how to recognize and prevent acute kidney injury. Finally, we'll discuss urinary retention, UTIS, age-related changes, kidney stones, and pediatric nephrotic syndrome, ending with a quick medication calculation review. Let's get started.
Chronic kidney disease, or CKD, is a progressive loss of kidney function that can eventually lead to kidney failure. As the kidneys become unable to filter waste and excess fluid, toxins build up in the blood and affect multiple body systems. End-stage kidney disease, ESKD, is the final stage of CKD, at which point renal replacement therapy is required to sustain life. Dialysis serves as an artificial replacement for some kidney functions by removing waste products and extra fluid from the bloodstream. Typically, dialysis is introduced when CKD has advanced to the point of life-threatening complications, such as dangerous electrolyte imbalances or fluid overload that cannot be managed with medications. In essence, dialysis is a critical supportive treatment that keeps patients alive when their kidneys can no longer maintain the body's fluid, electrolyte, and waste balance. For patients with advanced CKD, dialysis is not started at a fixed lab value or stage alone, but rather when severe complications of kidney failure emerge. One of the most urgent indications for dialysis is hyperkalemia, an excessively high serum potassium level. If potassium rises above approximately 6.0 milliequivalents per liter, and especially if electrocardiogram, ECG, changes, like peaked T waves or widening QRS complexes, are present, this situation is a medical emergency. Such a high potassium level can precipitate fatal heart arrhythmias, so immediate dialysis may be required to remove the excess potassium and stabilize the heart rhythm. Other indications for starting dialysis include volume overload, for example, pulmonary edema, that does not respond to diuretics, and severe uremic symptoms, such as encephalopathy or pericarditis, that threaten the patient's life. In chronic kidney disease, hyperkalemia is especially common because damaged nephrons cannot excrete potassium effectively, making careful monitoring of potassium levels crucial. Dialysis effectively clears potassium from the blood. However, it must be managed cautiously so as not to overshoot and cause hypokalemia, which can also destabilize the heart. The key point is that dialysis is initiated to manage these life-threatening imbalances that the failing kidneys can no longer regulate.
End-stage kidney disease, ESKD, refers to the final phase of CKD, where kidney function is minimal and life cannot be sustained without dialysis or transplant. Two major modifiable risk factors drive most ESKD cases: diabetes mellitus and hypertension. In fact, high blood sugar over years, diabetic nephropathy, and poorly controlled high blood pressure together contribute to about 2/3 of new kidney failure cases. Diabetes causes damage to the small blood vessels and filtering units, nephrons, in the kidneys over time, while chronic hypertension causes scarring and narrowing of renal arteries and glomeruli, gradually impairing filtration. This cumulative injury reduces the number of functioning nephrons and can eventually lead to kidney failure. Emphasizing tight control of blood glucose and blood pressure is therefore critical in CKD patients, as it can significantly slow the progression toward ESKD. Other contributors to kidney disease, such as certain medications, infections, or genetic conditions, exist. But diabetes and hypertension remain the leading preventable causes of end-stage renal failure, underscoring the importance of managing these conditions proactively.
For patients on hemodialysis, a properly functioning vascular access is their lifeline. An arteriovenous fistula, AVF, is a surgically created connection between an artery and a vein, usually in the forearm, that provides high blood flow for dialysis. Protecting this fistula is paramount. Nurses must never use the AVF arm for blood pressure measurements, blood draws, or IV infusions. Any compression or needle stick in that arm can clot off or damage the fistula, cutting off the patient's dialysis access. Patients are taught to avoid carrying heavy objects or wearing tight items on that arm as well, to maintain good blood flow. A key assessment is checking the fistula daily for a palpable thrill, a buzzing vibration over the site, which indicates blood is flowing through the connection. The presence of a thrill and an audible bruit on auscultation means the AVF is patent and functional. If the thrill is ever absent or noticeably diminished, it could signal a clot or failure of the access, and the healthcare team should be notified immediately. Patient education also includes keeping the site clean to prevent infection and recognizing signs of circulation issues in that arm, such as coldness, pallor, or numbness. Proper AVF care and surveillance ensure this access remains viable for the patient's ongoing dialysis treatments.
This section covers important renal diagnostics and related nursing care. One common non-invasive test is a renal ultrasound. For optimal imaging of the kidneys and bladder on ultrasound, the patient is usually asked to have a full bladder. A full bladder acts as an acoustic window that improves visualization, especially of lower urinary tract structures. Therefore, nurses should encourage fluid intake before the ultrasound, if not contraindicated, and ensure the patient doesn't void right before the procedure, so the bladder is adequately filled. Next, a kidney biopsy is an invasive procedure where a needle is used to extract a small sample of kidney tissue. The purpose is to examine the tissue under a microscope to determine the exact cause of kidney disease. For example, distinguishing glomerulonephritis, lupus nephritis, etc. Knowing the precise pathology guides targeted treatment and informs the prognosis. After a renal biopsy, nursing priorities include monitoring for bleeding. The nurse should check vital signs, the biopsy site, and urine output for any signs of hemorrhage, and the patient will often be kept on bed rest for a few hours, with frequent vital sign monitoring to ensure hemostasis. Another fundamental diagnostic is urinalysis. Certain abnormal findings in urine can indicate kidney damage. For instance, the presence of protein or glucose in the urine is not normal and suggests a pathology in the nephron's filtering ability or reabsorptive function. Healthy kidneys normally prevent significant protein from spilling into urine and reabsorb virtually all glucose, so proteinuria or glycosuria can point to glomerular damage or uncontrolled diabetes, respectively. Finally, when a patient undergoes a cystoscopy, an endoscopic inspection of the bladder, it's important to know what to expect after the procedure. Mild hematuria, urine that is pink-tinged, is expected for a day or two post-cystoscopy due to minor irritation of the urinary tract. The nurse should document this finding and encourage increased fluid intake to flush the bladder, which helps minimize bleeding and reduce infection risk. However, the nurse must also watch for signs of complications. If the patient experiences persistent bleeding with bright red blood or clots, significant abdominal or pelvic pain, fever, or difficulty urinating, these could indicate a complication such as bladder perforation or infection, and the provider should be notified immediately. By understanding these diagnostics and their aftercare, nurses can prepare patients appropriately and promptly recognize any abnormal results or post-procedure issues.
Patients with kidney issues often show fluid and electrolyte imbalances, which nurses must assess carefully. When a patient is fluid volume deficient, dehydrated, expect classic signs of dehydration: dry mucous membranes, decreased skin turgor, the skin tense when pinched, tachycardia, and low urine output, often accompanied by orthostatic hypotension. These clinical clues indicate the body is volume depleted. In the context of kidney function, an acute decrease in urine output, oliguria, coupled with a rising serum creatinine suggests an acute kidney injury, AKI, is occurring. AKI can have pre-renal causes, meaning it's due to inadequate blood perfusion to the kidneys. For example, Severe hypovolemic shock from trauma or hemorrhage can drastically reduce renal perfusion, leading to ischemia of nephrons and an abrupt loss of kidney function. This is why maintaining adequate blood pressure and circulation is vital in critically ill or injured patients. To prevent prerenal AKI, serum osmolality is a useful lab indicator of a patient's hydration status and solute concentration. A normal serum osmolality is approximately 275 to 295 millismoles per kilogram, which reflects a proper balance of fluid and solutes in the blood. If osmolality is above this range, the blood is more concentrated, which could mean dehydration. If it's below, the blood is more diluted, which could mean overhydration. In patients with kidney issues, close monitoring of fluid balance is essential. Nurses should track intake and output diligently, obtain daily weights, and watch for any signs of fluid overload, edema, crackles in lungs, hypertension, or depletion, hypotension, tachycardia. Early detection allows for timely interventions, such as giving intravenous fluids for dehydration or diuretics for overload to prevent further complications like electrolyte imbalances or uremia. Preventing AKI is always better than treating it, so prevention strategies are important. Maintain adequate perfusion. Avoid prolonged hypotension. Avoid nephrotoxins, e.g. excessive NSAIDs or high-dose contrast dyes whenever possible. And ensure patients are well hydrated before and after any procedures that could stress the kidneys. Educating patients to stay hydrated within any limits they have, and to be cautious with over-the-counter medications that can harm the kidneys is also part of good nursing care. Overall, attentive management of fluids and electrolytes can significantly reduce the risk of acute kidney injury and its associated morbidity.
This section addresses common urinary disorders and their management, with a focus on urinary tract infections, UTIs. One frequent cause of urinary retention in older men is benign prostatic hyperplasia, BPH. In BPH, an enlarged prostate gland mechanically obstructs the urethra, leading to difficulty starting urination, a weak urine stream, hesitancy, dribbling, and incomplete bladder emptying. Such men may retain urine in the bladder, which increases the risk of UTIs and can cause discomfort or backflow pressure on the kidneys. Treatment of BPH may involve medications like alpha blockers or 5-alpha reductase inhibitors, or surgical procedures to relieve the obstruction. But from a nursing perspective, recognizing the symptoms is key to getting patients proper evaluation. Urinary tract infections, UTIs, are extremely common, especially in women. Classic UTI symptoms include urinary urgency, frequent urge to void, frequency, voiding in small amounts often, and burning pain with urination, dysuria. These local urinary symptoms often appear before any fever or systemic signs. In fact, the presence of urgency and frequency in a patient should prompt the nurse to obtain a urine sample for urinalysis and culture to confirm infection and guide treatment. Once a UTI is identified, prompt antibiotic treatment is the priority intervention to eradicate the bacteria and prevent the infection from ascending to the kidneys. Alongside antibiotics, encouraging increased fluid intake is helpful to flush out bacteria from the urinary tract and to prevent stasis of urine. It's important to note that older adults with UTIs often do not show the typical symptoms. Elderly patients, especially those with cognitive impairment or dementia, may not develop a fever or complain of pain. Instead, they might present with confusion, new-onset incontinence, agitation, or a general decline in functional ability. This atypical presentation is sometimes called a silent UTI. Nurses must maintain a high index of suspicion when an older patient has sudden delirium or weakness. A UTI may be the underlying cause, even if they don't report classic symptoms. Timely recognition in this population is crucial, as untreated UTIs can quickly lead to more serious infections, like urosepsis, in older or frail patients. For all patients with UTIs, education is a key nursing role. We should teach proper perineal hygiene. For women, wiping front to back after using the toilet. The importance of completing the entire prescribed antibiotic course, even if symptoms improve, to fully clear the infection and prevent resistance. And measures to prevent recurrence. Preventive tips include urinating after intercourse, avoiding irritating perfumed products in the genital area, and staying well hydrated. By understanding these urinary disorders and their management, nurses can assess and intervene early and educate patients on how to maintain urinary health.
This slide highlights a few other renal and urologic considerations across the lifespan. Age-related changes in the urinary system are one aspect. As people age, the bladder's elasticity and tone decrease, which reduces its capacity to hold urine. Consequently, older adults tend to experience urinary frequency, needing to void more often, and nocturia, waking during the night to urinate, even with normal fluid intake. These changes are a common part of aging, though they can impact sleep and quality of life. Understanding that some increase in nighttime or frequent urination can be due to physiology helps inform our care and patient teaching. For instance, planning fluid intake earlier in the day, etc., to minimize nighttime trips. Another topic is kidney stones, renal calculi, and their prevention. For patients prone to kidney stones, the most common being calcium oxalate stones, staying well hydrated is one of the best preventive measures. Drinking plenty of water throughout the day ensures a higher urine volume, which dilutes the urine and makes stone formation less likely. Dietary adjustments can also help. Those with a history of calcium oxalate stones should consider limiting foods high in oxalate, such as spinach, rhubarb, beets, nuts, chocolate, and tea, that can contribute to stone formation. At the same time, maintaining adequate dietary calcium, as advised by their provider, is important because calcium in food can bind oxalate in the gut and reduce absorption. If a stone does form and begins to pass, prompt pain management is critical. Renal colic, the pain from a stone, is often severe, and interventions like analgesics or antispasmodics will be needed. Nurses should also monitor for signs of obstruction or infection in stone patients, e.g., if a stone is blocking a ureter, the patient may develop hydronephrosis or an infection above the blockage. Prompt medical or even surgical intervention, like lithotripsy or ureteral stent placement, may be required for large stones or complications, but prevention through hydration and diet is the primary focus. Finally, consider pediatric nephrotic syndrome, a kidney condition in children characterized by heavy proteinuria, hypoalbuminemia, low blood albumin, and edema. The loss of protein in the urine causes fluid to shift out of the bloodstream into tissues, leading to swelling in areas like the abdomen, face, or legs. These children are often treated with corticosteroids to reduce protein loss and may receive diuretics and albumin infusions to manage edema. A priority nursing consideration for nephrotic syndrome is vigilant monitoring of the child's blood pressure and intravascular volume status. Because of the fluid shifts and use of diuretics, they can be at risk for hypotension, if too much fluid is pulled from the vessels, or hypertension, if excess fluid accumulates or due to steroid side effects. Detecting any significant change in BP early allows the healthcare team to intervene. For instance, slowing down diuresis if the child's BP is dropping, or giving additional albumin or antihypertensives if BP is too high. Additionally, daily weights and strict intake output measurement are used to track fluid status in these patients. Nurses should also be alert for signs of complications of nephrotic syndrome, such as infection. These children are somewhat immunocompromised due to protein loss and steroid therapy. Or thrombosis. They can be hypercoagulable. By providing careful monitoring and support and educating parents on medication adherence and home monitoring, like checking urine protein with dipsticks, nurses help ensure children with nephrotic syndrome stay as stable and healthy as possible during treatment.
This slide gives you quick practice with different types of medication calculations, liquid oral doses, IV bolus dosing, and infusion drip rates. Take a moment to read each question and work through the math on your own. These examples help you strengthen accuracy and confidence in calculating safe medication doses.
In summary, this unit highlighted crucial points about renal failure and its management. Dialysis is initiated for life-threatening issues that arise in end-stage CKD. For instance, severe hyperkalemia with ECG changes or fluid overload refractory to diuretics demand prompt dialysis to prevent fatal complications. We also reinforce that diabetes and hypertension are the leading causes of ESKD, which underscores the need for diligent control of blood sugar and blood pressure in at-risk patients to slow the progression of kidney disease. In caring for hemodialysis patients, remember to avoid taking blood pressure or blood draws in the arm with an AV fistula. An intact AVF is the patient's lifeline, and a palpable thrill at the site indicates it's functioning properly. We discussed key renal diagnostics. For example, a full bladder can improve ultrasound visualization of the kidneys, and kidney biopsies provide definitive diagnoses that guide treatment. Monitoring was a recurrent theme. Whether it's checking for signs of fluid volume deficit, like dry mucous membranes and low urine output, to catch dehydration or AKI early, or observing an older adult for atypical signs of a UTI, such as confusion in the absence of fever. When it comes to infections, UTIs classically cause urgency and frequency, though in older adults they may present with confusion or weakness instead of fever. Prompt antibiotic therapy and hydration are crucial in managing UTIs to prevent complications. We also noted that simple measures like adequate hydration can help prevent kidney stones, and that accurate medication dosage calculations are essential for patient safety. These key takeaways provide a solid foundation as you prepare for NCLEX and clinical practice, ensuring that you prioritize safety, early recognition of problems, and evidence-based interventions in caring for patients with renal and urologic conditions.
Thank you all for your attention and engagement throughout this unit. We've covered a wide range of renal and urologic topics that connect directly to patient safety and nursing care. As always, if you have questions, feel free to reach out. Keep reviewing your notes, practice your med calculations, and apply this knowledge with confidence in clinical settings. Thanks again, and I'll see you in the next session.